Dr. Biju Raju is going to speak on SICS learning curve for Phacosurgeons.
Thank you very much, Dr. Sauser and the panel for giving me this opportunity. I have no financial interests. I'm quoting one of the high volume phacosurgeons, Dr. Uday Devgan. Every phacosurgeon should be able to do SICS. This is from the US. And we all know that this is a truth. And this truth has been reinforced into me only recently. So I must say that I was ignorant about it. And in heart cataracts, definitely there's no doubt in my mind that SICS will definitely be better than phaco. In fact, any cataract, SICS is the way to move forward. That's something which has been drilled into me by Saucer, and I'm really thankful that that has happened. And I always had this thing that I am a misfit here, because I was first trained as a SICS person, then went into phaco, then finally did my VR fellowship and stopped doing cataract surgery altogether for almost a decade, and then slowly started coming back to cataract also along with vitreoretinal surgery because of the kind of practice we have. And the mindset changed that, SICS from a low-tech surgery becoming an effective, cost-effective surgery with almost as good as or probably even better results than phaco surgeries. And it's a surgeon's skill. But the path is not always as green as we would think of. I had problems, I still have problems, and I'm trying my best to improve. So I'm just here to explain to you or share with you my challenges. So first of all, from topical, you are going into a local anesthesia. So you've never given injections for a long time. So for me, the best possible way to do injections was something which my dad had taught me, Dr. Raju. It's caruncular anesthesia. It's a single injection caruncular anesthesia because it goes into a safe portion of the orbit, and it is with a 26 gauge needle which passes through an anesthetized cornea, conjunctiva. So it's safe, painless, and patient friendly, and you can also reinforce. And most of the phacosurgeons don't take a superior rectus bridal suture. So that's another area where they struggle. Being a VR surgeon, I was comfortable, to be frank enough. But then if you have a problem, what we usually do is ask the assistant to depress, and the eyeball goes down, bringing the tendon more anteriorly, easy to catch. And it's been adequately explained about the amount of peritomy that needs to be done, and make sure you have a good cautery initially. I know it's because as a beginner or converting to SICS, you might not want to see too much of blood covering the incision. I use a straight cut with two back cuts, which about 5.5 mm with 2 mm back cuts, and then the usual tunneling. And I would say I'm still not very comfortable with the incision. I'm probably getting better, or sometimes I feel I'm going worse. But then it is a journey which has started, and I'm really going through it. And as phacosurgeons, we do 5 to 5.5 mm. 5.5 mm is good, but if you can make it around 5.5, as was described so well, your large CCC will help you to prolapse the nucleus better. Hydro dissection is an important step. Sometimes in phaco you do away with it because the fluidics will ensure. But in SICS you make sure there's a good hydro dissection to prevent chances of zonal dehiscence. And hydroprolapse is an easy way. You saw all the videos before. Now you can also use a hook and take the nucleus out. And if you have a large CCC, it comes easier. And again, I struggle at delivering the nucleus. Probably the forces are not right. You need to actually depress the wound correctly, take the nucleus out. Various methods, I don't need to explain them to you, but then always protect the endothelium. That's something we have to do. And visco express the fluffy cortical matter initially. That's one thing which I feel has to be stressed, because we don't do that in phacoemulsification. And Simcoe is the most cost-effective technique when you compare to bimanual IA, because you are looking at a surgery which you don't rely on the machines but on the surgeon's skill. Any IOLs, you can't do that with phaco, but any IOLs are possible with this surgery. And of course, you close the surgery with a watertight wound and then cauterize the conjunctiva. So my challenges, of course, as I said, superior rectus was never a problem. Incision, I'm still maybe trying my best to get better at it. Prolapsing the nucleus out of the back, it's okay. Delivering the nucleus is still a problem. Uh, those are the challenges I faced when I converted to SICS. It's an ongoing process, and I hope to improve, and maybe next AIOS I can give you a better picture of what I am. Thank you very much. Thank you.